thank the program committee for the kind invitation to participate and speak on this topic today. Hopefully it's okay that I'm talking a little bit about an open surgical approach as well in my talk. It'll be a balanced view. I have no relevant disclosures. So it turns out this controversy has been around for a while. This is a paper which was published almost 10 years ago. It was a large single institutional series of over 2,000 patients undergoing carotid endarterectomy in the 1990s, and 360 procedures were performed in octogenarians. There was no difference in stroke. It was about 1% in both groups. However, there was a higher mortality rate at 1.9% compared to 0.8%. And while the combined stroke and death rate was higher in octogenarians, it was about double at 3% versus 1.5%. This was largely due to the fact that the 80-year-olds that were getting operated on did have asymptomatic carotid stenosis. So the authors concluded that CEA risk may be higher in octogenarians, but this is due to the higher risk noted in symptomatic octogenarians, and I think most of us would offer those patients operations anyway. And the outcomes at about 3% remain within accepted national guidelines justifying CEA over best medical therapy. So we shouldn't be excluding octogenarians. And fast forward to this paper, which was published in 2020. This is a large NISQIP-based study, which also looked at the octogenarian patient population undergoing CEA. Once again, octogenarians had a slightly higher mortality rate. They also had a higher risk of return to the operating room, but they had a similar rate of stroke and a similar rate of stroke and death. And the authors concluded that the 30-day outcomes in octogenarians are actually comparable to younger patients. There may be a slightly higher mortality rate, but the mortality rate is still low and acceptable at 1.2%, and they concluded that CEA is safe in octogenarians. So maybe it's not that age is the most important risk factor, but perhaps frailty is a better marker for whether or not we should move forward with a carotid revascularization procedure. And this is a large VQI-based study out of Shipra Arya's group. They categorized patients into 3 different frailty categories based on the Risk Analysis Index, which takes into account age, low body mass index, CHF, end-stage renal disease, and cancer. And these are kind of things that I'm sure many of us, when we're seeing these patients in clinic, self-categorize ourselves based on our clinical judgment. Risk Analysis Index was not associated with stroke risk, which makes sense. But in terms of long-term mortality, they did find that frailty did increase the risk of long-term mortality in a stepwise fashion, both in asymptomatic as well as symptomatic individuals. And they concluded that really it's about frailty, and that should be considered in the decision to proceed with CEA to ensure good long-term survival. And you should really be balancing that versus best medical therapy in these individuals. So the rationale for treating asymptomatic severe carotid stenosis still comes from these 2 multi-center randomized controlled studies, the ACAS as well as the ACST study, and many of us are familiar with these studies. They're still being cited as our indications for moving forward to revascularize these patients. The number needed to treat was 17 in both of these trials to prevent 1 stroke, and in both trials the risk of stroke was halved with CEA versus just best medical therapy alone, and still represent level 1 evidence supporting the treatment of asymptomatic severe carotid stenosis in the current era. So these are the most recent SVS guidelines regarding treatment of carotid stenosis. And essentially, if you're a low surgical risk patient, the SVS recommends carotid endarterectomy with best medical therapy, provided that the perioperative risk of stroke and death can be maintained at less than 3%. And this was the accompanying document, the implementation document, which essentially says that for neurologically asymptomatic individuals with severe stenosis, you can choose any of these 3 modalities, CEA, TCAR, or transfemoral carotid stenting, provided that the patient has a 3 to 5 year life expectancy, and you can keep that perioperative risk to 3% or less. So the take-home points really are that really restate the primacy of carotid endarterectomy in the treatment of asymptomatic severe carotid stenosis. It does give some leeway to the practitioner in terms of the mode of therapy, but you really have to make sure that the patient's life expectancy is at least 3 to 5 years, and that risk, that perioperative stroke and death risk, is less than 3%. And interestingly, neither document calls out age specifically, which makes sense. So just to talk about the high-risk criteria for each of these different modalities, because that's how we're going to keep that risk less than 3%. Obviously, for carotid endarterectomy, there are physiologic as well as anatomic high risks. In my practice, those patients that have had a prior radical neck dissection performed by ENT or radiation, where that skin is really leathery, or if they've had a restenosis after carotid endarterectomy, those are the patients that I'm thinking about applying TCAR to. The physiologic risks at our institution, at least, are not so much a high-risk criteria. Patients with congestive heart failure who are compensated generally can still get general anesthesia or a regional block and a carotid endarterectomy. Obviously, if they have unstable angina or other active coronary symptoms, those should be addressed first before you treat their asymptomatic carotid stenosis. Moving on to high-risk issues associated with transfemoral carotid stenting. These are the different types of arch angulations which we're aware of, and with advancing age, we know that the prevalence of type 2 and 3 arches increases. In fact, the increased stroke risk noted amongst octogenarians at 13% in the crest lead-in phase was attributed to arch angulation, so something to certainly keep in mind. Some of the other unique challenges of transfemoral stenting, and Dr. Petrov talked a little bit about arm access, but with this modality, you have to cross any plaque in the arch as well as in the carotid lesion before placement of your distal embolic protection device, so that increases your risk of embolic phenomena. The distal ICA really needs to be straight for tracking and well seating of that embolic protection device. And if patients have aortoiliac occlusive disease, then you have to think about upper extremity access, and a left carotid and bovine anatomy may be better approached from the right arm, whereas a left carotid stenosis in a patient with a pre-existing carotid to subclavian bypass may be better approached from the left brachial. So just additional considerations from a technical perspective for this technique. So again, the high-risk criteria for transfemoral carotid stenting then has to account for the fact that if there's tortuosity at the arch level, the common carotid or internal carotid artery level, if there's heavy atherosclerotic burden of the arch, then that's going to increase the complexity of that procedure, and you really want to avoid placing stents in someone with a very heavy calcified carotid lesion. The stent simply just won't open, and I really avoid it. All stents in very calcified carotid lesions. High-risk criteria for transcarotid artery revascularization, and this has really revolutionized the way that vascular surgeons treat carotid artery stenosis. And obviously, cerebral protection happens with flow reversal with this particular device. You do have to have good anatomy for TCAR, and the most common exclusionary criteria is not having that 5 centimeters of running room between the clavicle and the start of that lesion. Neck radiation, while listed here, is not what I consider high risk for TCAR. Usually you can make that small incision at the base of the, between the two heads of the sternocleidomastoid and access that common carotid artery without any issues. But again, a heavily calcified carotid lesion, I really hesitate placing any stents in that patient, especially if they're asymptomatic. It's just not a good idea. It doesn't expand very well. So this is a paper out of the Vascular Quality Initiative looking at the impact of age on in-hospital outcomes after these 3 different carotid revascularization modalities. As you can see from the bar graph, octogenarians actually make up a significant proportion of all 3 ways of revascularizing the carotid. 25% of TCAR procedures, 15% of those undergoing TF-CAS, and 17% of patients undergoing carotid endarterectomy. And based on the table on the right-hand side, as you can see in the octogenarians, TCAR had much more favorable outcomes when it came to stroke, stroke TIA, stroke death, or stroke death and myocardial infarction. And when those comparisons were made between TCAR and CEA, they were essentially equivalent. So this paper showed that TCAR really is the safer, minimally invasive method for treating carotid stenosis in octogenarians, and it has similar outcomes compared to carotid endarterectomy. This is a paper that looked at the outcomes of TCAR versus TF-CAS based on aortic arch type and degree of atherosclerosis, and it's just an example of how the VQI does collect very sort of technical, granular information about these types of procedures. And not surprisingly, TCAR fared better than TF-CAS, no matter what the aortic arch angulation was and no matter how much arch atherosclerosis was. and certainly makes sense that TCAR has better outcomes compared to transfemoral carotid stenting in both of these challenging anatomies. And finally, this is a VQI paper which summarized the 7 years of the transcarotid artery revascularization surveillance project and really compared very large numbers to both transfemoral stenting as well as endarterectomy. And from this paper, once again, we saw that transfemoral stenting had a higher rate of stroke and death compared to TCAR as well as CEA. CEA had a slightly lower rate of stroke and death compared to transcarotid artery revascularization. However, the surgical arm did have a higher rate of both myocardial infarction and cranial nerve injury compared to TCAR. They concluded that CEA and TCAR both have a lower stroke and death rate compared to transfemoral stenting, and if a carotid stent procedure is being contemplated, TCAR is better than transfemoral stenting. This is an algorithm for carotid stenosis treatment, which closely mirrors what I use in my practice. And again, we're talking about asymptomatic patients with severe carotid stenosis. If they're a good surgical risk candidate, and I think they have a 3 to 5 year life expectancy, regardless of what their age is, they're going to get a carotid endarterectomy. If they're of high surgical risk based on anatomic or physiologic factors, then I'm choosing between TCAR primarily versus best medical therapy. If they don't have great anatomy for TCAR, then essentially I'm pushing hard for best medical therapy. I'll end with a case presentation. This is an 88-year-old woman who was sent to me. She had had a prior right carotid endarterectomy in an outside hospital, followed by carotid stenting for restenosis. All of that was done at another facility, and as you can see, she's developed severe in-stent stenosis of that carotid artery. I don't know if she had any cognitive issues, Dr. Petrov. I'm going to ask you that question when we are discussing things next. And then, as you can see from the Wheatlander in the field, I performed TCAR on her. And she was back at the casinos later that week, so she did well. So in conclusion, octogenarians should not be considered high risk for carotid intervention, and frailty is probably a better marker for increased mortality after CEA based on that Shipra-Aria paper. Patients being considered for asymptomatic carotid revascularization should have that 3 to 5 year life expectancy and that less than 3% perioperative complication rate. Excellent outcomes have been demonstrated in the VQI after CEA and TCAR across all age groups, but if you're considering transfemoral stenting, really you should avoid doing it in patients older than 77 years of age. CEA is the initial treatment of choice in a standard surgical risk patient, and TCAR is a preferred minimally invasive approach, anatomy permitting. Thank you for your attention.